Poripan, and I will start with the clinical trials. I know already that is a tough subject and it will be like, reading more than understanding the things. So, the first thing that we will start with is a challenge with the interpretations of the results. So, I have 3 points to talking about these things like fundamental issues, what are the problems regarding this, and the data level concerns, and the other thing is validity concerns about this topic. So let's start with the fundamental issues. The first one is uncertainty of observations. Clinical study results can be affected by errors such as measurement impression, sampling variability, and biological differences, making it hard to determine if the results truly reflect the phenomena being studied. It's maybe affected by many errors, like there is not accuracy of the measurements, or there is a sampling variability, or there is a biological difference. So these errors make these observations uncertain. And we have another problem is like a sample and population generalizability. Like studies are often conducted on a specific groups that may not represent the wider population. Maybe we select the group, but it's not represent the wider population, limiting how well the findings can be applied to all individuals with the condition under the investigation. So, again, what are the fundamental issues? Uncertainty of observation. Clinical study results can be affected by errors such as measurements, impression, sampling variability, and biological differences, making it hard to determine if the results truly reflect the phenomena being studied. Sample and population generalizability. The studies are often conducted on a specific group that may not represent the wider population, limiting how well the findings can be applied to all individuals with the condition under the investigation. Now we go to the other point of this is data level concern, like statistical and medical significance. Statistical significance measures if the results are unlikely to occur by chance, but it doesn't necessarily mean the results has a clinical importance. Like we want to know if the results occur by chance or unlikely to occur by chance, like measures that this is statistical, but doesn't necessarily mean that the results has a clinical importance. For example, a small change in a blood pressure may not have any practical therapeutical impact. Like this, like a small change in the blood pressure, maybe it doesn't has any practical therapeutic results or impact or any effect, but we just measure it. And we have the other thing is validity concerns. So we have two things: internal validity and external validity. Internal validity, it means the extent to which the study design, methods, and measurements tools ensure that the observed effects are truly due to the intervention being tested, free from bias and confounding variables. It means accuracy. I can say that internal validity is accuracy. We subdivided all these words. The extent to which the study design or methods or measurements tool ensure that the observed effects are truly due to the intervention being tested. Like we tested a drug, like we making a diagnosis, whatever that, and it has a good effect. Internal validity, it concerns about the the subject itself, and free from bias and confounding variables. That's mean accuracy, how it's accurate. That's what we mean exactly by the internal validity. But the external validity, it means the extent to which study findings can be generalized to the other settings, population, or time periods beyond the study sample. And that's what we can say generalizability. That's mean that's mean the finding or the results that we get from this study, that we can do it for other people or for whole population. We just make the experiments in a smaller group, but it's maybe that's the results are related to the whole group. That's what we mean exactly by the external validity. So I try to make just one word what it means. Internal validity, accuracy. External validity, it's mean generalizability. There is something is called trade-off, and the trade-off is when you have to balance two conflicting factors where improving one may be worsening the other. And what is happening here in research, the trade-off is often between internal validity and external validity. When we just focus to improve the accuracy, for example, so just you improve the internal validity, in contrast you worsen the external validity. Just you making a balance between opposite things, internal validity and external validity. Internal validity is it concerned about how accurate these effects, how accurate these results, and the external validity, it just if that's applied to whole population or not. So the trade-off is just balance between two conflicting factors between the internal validity and external validity in our topic. So this is the first point, is about the challenge with the interpretation of the results. We talk about the fundamental issues, we talked about the data level concerns, and we're talking about the validity concerns. Let's talk about the other subject, risk to true results. In the clinical research, the validity and reliability of the results can be affected by two types of errors. So we have two types of errors. We have systematic errors and random errors. I want to know what is the difference between them, what are the, like the examples of them. So systematic errors is constant, predictable errors in the study design or execution that lead to inaccurate conclusion, often introducing bias. That's mean we predict these errors, we know these errors because maybe we design or we make this study design many times. Just like constant predictable errors, which is so important to mention that in a study design or execution that lead to inaccurate conclusion, often introducing bias. And we want to know to discuss what is bias is. They do not decrease with the larger sample sizes or repeated measurement, and that is a good point to know it. What is the problem about the systematic errors? If we make just the sample more or we increase the size of the sample, that will not decrease. There is no effect. You can't reduce these errors, okay? And if you just repeated these measurements, also that's not improve anything. That's why we say many times it's constant and the predictable errors, because it doesn't even decrease if we just make the sample large or just we repeat the measurements. It's error, that's mean it's error. So we want to know what is the key forms of systematic errors, biases. And a bias is systematic deviation that misrepresent the true relationship between the variables or the effect of an intervention. It's like systematic deviation, and you know what is deviation is? That misrepresent the relationship between the variables. I mean the true relationship between the variables. The real relationship between the variables, it's completely deviate if we are just make a study that discuss the relationship between the variables, or the problem is the effect of an intervention. So we have multiple types of bias, and when we discuss the multiple types of bias, we can know completely what is the systematic errors. Selection bias. This is the first one. Of course, when study groups differ in a ways that affect outcomes, often due to poor randomization. I mean the selection bias, when we select the groups or individual for this study group, they are differ maybe to generalize the whole population, and that is mean that the effects or the outcomes it's really poor and it's really not reflect the whole population. That's mean the selection bias. Of course, when the study groups differ in a way that affect the outcomes, often due to poor randomization. We have the other one is performance bias arises when the participant's behavior is influenced by knowing their treatment group. Like, we make the study group, we make control, we make a study group, and the participants, they know already they may be treated, or they know what is the treatment is, or they are not, and that is affect the behavior, and they affect also the answers, so it will be a bias, you know. Detection bias occurs when the outcome assessment are influenced by knowledge of a treatment assignment. When we just know what is a treatment assignment, we know what is a group like this. Irritation bias happen when a dropout rates differ between groups, potentially skewing the results. So you don't understand what is a tradition bias is, and the tradition bias is you know it's like in a study some people might drop out. What that mean? They maybe leave the study for different reason. If more people drop out from one group than another, it can mess up the results. You have two groups and you study two groups, and then start the people they leave maybe because of adverse effect or side effects or something, and the other group just no one leave, so the results will be incorrect. For example, if more people drop out of a treatment group because of a side effects, the group left behind look better because they are the ones who didn't have a problems, and this makes the treatment seems more effective than it really is. Okay, so that is the tradition bias. Publication bias, the tendency to publish studies with the positive outcomes while disregarding studies with the negative or null results. Like, I publish the results and I publish the studies with all positive outcomes and ignore completely what are the negative or the null results, and that is what we can call it is a publication bias. We have also confounding, and the confounding is the distortion of the association between an exposure and the outcome by a third variable that is related to both but not a causal factor. And we have to just we have to know what is the like example how we can know that. Imagine you are studying whether the coffee drinking, here exposure, causes heart disease, which is outcome. You find that the people who drink more coffee seems to have a higher risk of heart disease, but there are a third variable like smoking. Smokers are more likely to drink coffee, and the smoking is also the non-cause of the heart disease. So smoking is a confound. It's related to both coffee drinking and heart disease, but it's not the cause of relationship between two. So smoking is what really causing the heart disease and not the coffee. And in this case, confounding makes it look like the coffee is causing the heart disease when in reality it might not be. So the random errors, variability in data that occur by chance, which can obscure the true effect of an intervention, but can be reduced by increasing the sample size, which is completely negative from the systematic errors. Like, how can we know? We just make an example. Imagine you are measuring the height of the people in a room. You use a measuring tape, but sometimes you might read it wrong because the tape is a little bit bent, or you measure from different angle. This is small mistakes happens randomly, and it's not because you are doing something wrong, it's just by chance. For example, you measure the height of three people. Person 1 is 170, person 2 is 160, 57, in person 3 is 169. So but let's say the measuring drops a slipped a little when you measure person 3, and this is actually 170. This random mistake is the random error, and it's completely can be decreased by increasing the sample size, which is completely opposite from the systematic errors. This can be mitigated by an increasing sample size, which helps to reduce the variability and increase the precision of estimates, and using advanced statistical methods to quantify uncertainty and reduce the impact of random errors. And now we discuss the interplay between the systematic and the random errors. The systematic and random errors interact in ways that complicate the reliability of study findings, while larger sample sizes help reduce the random errors. They do not correct the systematic errors. Thus, the larger study may still be misleading if it's affected by biases or confounding factors. Researchers need to carefully control both types of errors to ensure the valid and reliable results. And I will talk about also the other important things. Before that, I will just make uh, a whole view. Risk to the true results, it's subdivided into systematic errors, which is known as a bias, and then we know the types of the bias. We have the selection bias, performance bias, detection bias, attribution bias, publication bias, confounding, and then the other type is called random errors, and we discuss what is random errors, and we know that the most specific that it can maybe reduced by increasing the sample size. And then we enter the third topic or third title. It's overcoming risks in a study design or adapting a clinical trial design to research objects. So the first point we will talk about the purposes of a clinical trials. I just repeated it. What are the purposes of a clinical trial? So we have the first one is a treatment, evaluating the safety and efficacy of a new therapies or medical interventions efficacy. I want to know this is our new therapies, and I want to evaluate what are the safety and efficacy of this efficacy of a new therapy. And the other thing is a prevention, testing strategies to prevent the onset or progression of disease such as a vaccine or lifestyle modification, and that we use it also for the diabetes mellitus or other things like prevention of the disease to be happen. Diagnostic assessing the accuracy, sensitivity, and the specificity of novel diagnostic tools. We use also screening, identifying the methods to detect the disease early like a cancer, and improving the outcomes through timely intervention. And we have also health service science, optimizing the healthcare delivery system to improve the patient outcomes and efficiency. And the basic science, investigating fundamental biological mechanism to enhance our understanding of human health and disease. So these are the purposes of clinical trials, like a treatment, prevention, diagnostic, screening, health service science, and a basic science. Okay, let's go to the other point, is the study types. So we have two types of a study, like retrospective and prospective study. So let's start with retro. Retro, that's mean behind. So we will looking for something behind, for past things. Retrospective studies look at the past records or data that already exist, like medical histories or like survey. That's why we called it retrospective studies, because we look at the past, we look behind. So we look at the past records or the data that is already exist, like I don't ask for it, it just present. So like medical histories and the surveys. The purpose is good for generating ideas or finding association between things like smoking and lung cancer. Like we just make these records and we just study it, and maybe that's generating ideas. Maybe I discover there is this association between things like smoking, so like it's a factor for lung cancer, like this. But what is limitation? Hard to prove the cause and the effect. Why? Because the data was not collected for the study. It's like this data just put in these records not for my study, so it's hard to prove that is the cause and that is the effect. Maybe that's by chance happen, so I can't prove that. It's hard to prove the cause and the effect because the data was not collected for this study, and there may be biases or missing information in that. Now we go to prospective studies, and pro is something that is related to the future, and the data source is collecting new data over time by observing people. I will do this study, and I will now start with collecting data, and this data by just observing the people, following a group of people for several years. Like, I just noticed these people and I just following them, observing them. It's better at establishing the cause and the effect because the researcher can control the data collection, can design it to follow the subject through time, because they choose the subject, they choose the data, they control everything. So it's better way to know what is the cause and what is the effect. So the advantages helps in studying how things develop, because we just observing for over several years. You can imagine that how is smoking over time lead to the cancer. So yeah, by smoking you can see how that is lead to the cancer. So we have two types of study types. We have retrospective studies and the prospective studies, and we can just conclude that the prospective studies is good to prove the cause and the effect of our study. Then we have another point, it's called interventional and non-interventional studies. So what is interventional studies? It means clinical trials, which is our topic. Researchers give a treatment or test it to the participants. So they give them a treatment or they give them a test meant to see how a treatment affect people directly in a controlled setting. It means like we want to know how that affect these participants, even it's a treatment or a test. But non-interventional studies, which is mean observational studies, researchers only watch and record what happens naturally, helps understand how disease progress or how treatment work in a real life without changing anything, just watching. What is the difference between interventional studies? Like, I just gave them this treatment and I want to see how this treatment affect these participants, or I do a test for them and I want really to know how this test affect them. But like, something I do that for them. But non-interventional studies, I didn't do anything in you. They just keep their life as they just doing the participants. They do everything as naturally do. I didn't ask them to do anything. I just watch. The only thing that I do, I just watch and record what is happen, and that is important to know what is the progress of the disease. I can know what is a treatment work, and when I see the treatment, because he just take this treatment for his own selves, like this treatment for this disease, naturally taking it without any, I didn't ask anything, I just watch. The other point is key aspects of the interventional methods or models. Definition, the hypothesis, and the study type. Every clinical trial, because the interventional models, I mean by it, it's a clinical trial. That's we give a treatment to this patient and we make a test for this patient. Every clinical trial could begin with a clear hypothesis that guides a design process determining whether the study is interventional or non-interventional, retrospective or prospective. Okay, so it will be the clear hypothesis and that it will be guide the design. Interventional models and control types. The selection of the right interventional models impacts the study reports on efficiency. Some common design include. So now I will talk about some common study design that we as interventional models. So we have a single arm study, we have a parallel design, and we have a crossover design. So I will discuss each one alone. Single arm studies, it means all the participants receive the same treatment without control group. You mean all these participants receive the same treatment, there is no control group, the control group which is received placebo or something that is not the treatment. No, all the participants that I have, they will receive the same treatment. So that's why we call them as a single arm. The advantages, it's a simple design, it's cost effective, it's useful for safety testing or rare diseases. It's good for the safety and it's good for the rare diseases. The disadvantages, there is no control group, so I can make a comparison. It's hard to attribute the results to the treatment alone, so we have to know if this person without the treatment is better or not, or with the other treatment. So that is the disadvantages of this study. And we have also the parallel design, and the participants are randomly assigned to the different groups treatment or placebo. That's mean we subdivided to the participants randomly without any factors or something, like just we subdivided into control group and the other one is a treatment group, and the person itself, he doesn't know anything that he is a treatment or a placebo. So that reduces the bias through randomization and provides strong causality evidence, because the person itself, he doesn't know if he's in treatment or a placebo, so he will talk what he feels real. But the disadvantages requires large sample size and the other important effect that resource intensive. Crossover design, participants receive multiple treatment in sequence acting as their own control. They will, receive multiple treatment after treatment. Efficient with small samples and reduces the variability between the subjects. It's good for small samples and it will reduce the variability, but it's risk for carryover effect and not suitable for diseases that they change over the time or irreversible treatment. So these are the disadvantages of crossover design. Now we go to randomization and allocation. Randomization, the process of assigning the participant to different group by chance, like there is no rules, I just choose it by their chance and pick them and got them to the other groups. So the process of assigning participants to different groups by chance, reducing the bias and ensuring that confounding factors are evenly distributed across the groups. So we have multiple types of the randomization. We have a simple randomization, block randomization, and the stratified randomization. Simple randomization assigns participants randomly without restrictions, but maybe cause imbalances in small samples. The problem when they are small, that maybe that cause imbalance. But the block randomization ensures balanced group sizes by predefining blocks, like we separate them into the blocks and each block has the same number of, it's in the same number, and the participants are assigned in the blocks, making sure each group has the same number of the people. Stratified randomization, a method of randomization that ensure equal distribution of important characters, like we subdivided them according to the age, to the gender, and across the treatment groups. And about the plating or masking, it's a way to reduce the bias by keeping the treatment information hidden. Like we have three types of a blind. We have open label, single blind, double blind. Open label, both participants and researcher know the treatment. That's mean the participant know the treatment, the researcher know the treatment. What is good about this is easy to conduct because everyone know everything, but the cons is high risk of bias, But the single blind, either the participants or the researcher doesn't know the treatment. That's mean maybe the participant doesn't know the treatment or the researcher doesn't, one of them, doesn't know the treatment. And that help reduce the bias from one side. Some bias may still occur that mean from the side that knew already that treatment. The double blind, neither the participant nor the researcher knows the treatment. I mean, the participant and the treatment, they don't know what is the treatment is, and that just reduces the bias and the placebo effects. But it's more complex to organize, but it's a gold standard. And then we go to the outcome measures are crucial in clinical trials as they determine how effective an intervention is. These measures are divided into primary, secondary, exploratory outcomes, each serving a different role in the study. So I will divide them into primary outcome and discuss them, secondary outcome, exploratory outcome, and the importance of it. So the first one is primary outcome. The primary outcome is the main variable that directly addresses the study's central hypothesis, and it's typically related to a significant clinical change, reduction in tumor size or improvement in the disease score. It's the basic thing. It's the most variable and the main variable that directly addresses the study's central hypothesis. The primary outcome must be chosen carefully because it's a main variable, to ensure that study has enough statistical power to detect a meaningful effect. And this outcome dedicates the statistical analysis plan and serves as a key measure of success. So the primary outcome is so important. Then we're talking about the secondary outcome. These are additional aim points that provide supplementary insights such as long-term safety or quality of the life. Secondary outcome can add depth to understanding of an intervention effect since they often involve multiple comparison, adjustment, or necessary to avoid the false positives. Secondary outcomes are typically seen as a hypothesis generating rather than definitive, like addition, because it's talking about, we say it's secondary outcome, so we can know it from the title itself. Exploratory outcomes. These outcomes are used to generate a new hypothesis and guide the future research, and they are less defined at the start of the study and may involve biomarkers or post hoc analysis. Exploratory outcomes are generally considered as preliminary and should be interpreted with caution, and they help researchers discover unexpected effects or mechanism, but they are not used to draw the final conclusion. The importance of outcome selection. The careful selection of primary, secondary, or exploratory outcomes is the key for scientific credibility and methodological rigor. Clear definition minimize the bias on maximize the study ability to provide meaningful results, while defined outcomes ensure that the study design is optimized to detect meaningful differences while also adding context and depth through the secondary and exploratory outcomes. And a final topic for me, it's the types of endpoints. So I subdivided them into surrogate endpoints, composite endpoints, event driven signs. Okay, so by the definition, the surrogate endpoints, it's indirect measures used to predict the clinical outcomes, like using the blood pressure to predict the heart disease risk. But the surrogate endpoints need strong evidence to reliably predict the true clinical benefit. If they don't match the actual outcome, conclusion can be misleading. Composite endpoints combine several outcomes into one measure, like death, heart attack, stroke, all in one. Composite endpoints increase the event rates, making the study more powerful, but interpreting them can be difficult if the individual outcome have very different levels of importance. Event-driven design the trials based on the occurrence of a specific number of events like heart attack, cancer progress. More efficient because the study is focused on the events instead of fixed time periods, but the statistical method need to account for when and how these events occur to avoid the bias. And finally, the sample size and eligibility. The sample size calculation determines how many participants are needed in a study to detect a true effect. We want to avoid type 1 errors and type 2 errors, and as size ensures the study has power to detect the real difference considered except the effect. The difference is in variable spread out of the data is. And we have also inclusion and exclusion criteria defines who can or who can't participate in the study to ensure the sample is relevant and representative, but carefully choosing criteria improve the study's ability to generalize the results. I mean external validity, as we mentioned it earlier, and keep the study scientifically rigorous. Internal validity. Okay, so by this one we can finish the first part of the lecture one, and the other time it will completely small, so we will discuss this later. I hope that you understand for me. Thank you for listening.